In a town of 4,000 people, 14 deaths in 2 years is not unusual. People get old, people get sick. And in small, rural communities, when a doctor says someone died of natural causes, nobody argues, nobody questions, nobody asks for a second opinion. That was the problem. The doctor's name was Bernard Kale. He had practiced general medicine in Harwick County for over 19 years. Trusted, respected, known by first name in every diner and hardware. When he signed a death certificate, the family accepted it. When he listed a cause of death, the county clerk filed it. Nobody looked twice. Until a newly appointed county health officer named James Whitfield ran a routine mortality audit, the kind of administrative review that most small counties do every 5 years. He wasn't looking for anything specific. He was filling out a spreadsheet, but when he sorted the data by certifying physician, one name appeared so many times it didn't look like a column and it looked like a pattern. 14 certificates, 23 months, 1 doctor. Whitfield printed the list and stared at it for a long time. Then he picked up the phone. Whitfield called the state health department's mortality oversight division. He expected a standard response, a form to fill out, a queue to join, a call back in 3 to 5 business days. Instead, the man who answered asked him to hold. He was transferred twice before reaching a senior epidemiologist named Dr. Paul Denning. Denning asked Whitfield to read the names off the list, all 14. He listened without interrupting. Then he asked one question. He asked whether any of the deceased had been patients of other physicians in the county before switching to. Whitfield hadn't checked that. He pulled the records that afternoon. 11 of the 14 had previously been registered with other local practitioners. All 11 had transferred to Kale's practice within the last 3 years. Not referred, not relocated. Transferred by choice, or at least that's what the paperwork showed. Denning drove out to Harwick County himself 2 days later. He spent a morning reviewing Kale's filed certificates in the county records office alongside. What he found wasn't dramatic on the surface. The causes of death were all plausible: cardiac failure, respiratory decline, complications from existing conditions. Every certificate was correctly formatted. Every signature was clean. But one detail appeared across 9 of the 14. The listed time of 9 patients had died between 11 p.m. and 3 a.m. In a general practice setting, a physician being present at that hour for a natural death was not impossible. But 9 times in under 2 years, for patients who had not been admitted to any hospital or care facility, it was deeply unusual. Denning closed the folder and looked at Whitfield. "Who else knows about this list?" he asked. Whitfield told him nobody else knew. He had gone directly to the state health department without telling anyone locally. Not his assistant, not the county administrator, nobody. Denning said that was the right call. He didn't explain why. He didn't need to. Back in his office, Denning requested the complete medical records for all 14 deceased patients through a confidential state channel. It took 4 days to compile everything. When the files arrived, he brought in a forensic medicine consultant named Dr. Marcus. Hale had spent 16 years reviewing disputed cause of death determinations for state and federal investigations. He reviewed all 14 files. His preliminary assessment was cautious but clear. In 6 of the 14 cases, the documented symptoms recorded in the patient's final visits were inconsistent with the listed cause of death. Not dramatically inconsistent, subtly. The kind of inconsistency that a busy county clerk would never catch. The kind a grieving family would never think to question. Hale flagged one case in particular, a 73-year-old retired schoolteacher named Howard Greer. Greer had visited Kale's office 9 days before his death, complaining of fatigue and mild chest discomfort. Kale had documented the visit as routine. No referral to a cardiologist, no follow-up schedule, no blood work ordered. 9 days later, Greer was dead. Cause listed: cardiac arrest. But Hale found something in Greer's file that didn't belong. A prescription, issued by Kale 4 days before Greer died. A medication with no documented medical justification in any of Greer's prior record. A medication that, in elevated doses, could cause cardiac arrest. The medication was called digoxin, a legitimate cardiac drug. Used correctly, it regulates heart rhythm. Used incorrectly, it accelerates it beyond what the heart can sustain. In controlled doses, it saves. In elevated doses, it stops them. And it leaves almost no trace in a standard post-death examination, unless you know to look for it specifically. No toxicology had been ordered for Howard Greer. No autopsy had been requested. The family had accepted the death quietly and buried him. Hale went back through the other 13 files looking for the same prescription. He found it in 4 more cases. All 5 patients had been prescribed digoxin by Kale within the last 2 weeks of their lives. None of them had a prior documented history of the cardiac conditions that would justify the prescription. Denning took the findings directly to the state attorney general's office. A criminal investigator named Agent Thomas Rourke was assigned the case that same afternoon. Rourke's first move was quiet. He didn't contact Kale. He didn't alert the county. He simply requested a full financial audit of Kale's personal and professional accounts going back 5 years. What came back 3 days later shifted the entire investigation. Cale was not in financial trouble. He was not in. He had no gambling records, no addiction history, no obvious personal motive. But one transaction appeared repeatedly across 4 years. Monthly deposit, small amount, irregular enough to avoid automatic flagging, always in cash, always made at a branch 40 minutes from Harwick County, always on the same day of the month, the day after a patient died. Rourke spent 2 weeks tracing the deposits backward. Cash transactions are deliberately difficult, but the pattern was too consistent to be coincident. 14 deaths, 14 months with unusual deposits. The amounts varied, sometimes $800, sometimes just over $2,000. Never enough to trigger a formal bank alert, always just under the threshold. That kind of precision doesn't happen by accident. Rourke brought in a financial crimes analyst named Victor. Marsh spent 4 days cross-referencing the deposit dates against Cale's patient death record. 11 direct matches, 11 times. Within 36 hours of a patient dying, cash had been deposited into an account connected to Bernard Cale. Marsh then asked a question nobody had thought to ask yet. He asked who benefited financially from the. Rourke pulled the probate records for all 14 deceased patients. Most were unremarkable: estates passed to adult children, properties transferred through standard inheritance. But 3 cases showed something different. In 3 separate estates, a recently updated will had directed a portion of assets toward a private care and wellness. All 3 trusts had been registered within the same 18-month window. All 3 had the same registered. A man named Colin Dresser. Dresser had no medical background, no legal credential. His only registered profession was listed as a private estate consultant. Rourke ran his name through the state database. No criminal record. But one detail appeared in a civil court filing from 6 years earlier. Dresser had been listed as a character reference in a professional dispute case. The man he had vouched for was Bernard Cale. They had known each other for. Rourke leaned back and closed his laptop. The deposits weren't random payments. They were commissions. Rourke moved carefully from that point forward. A case built on financial patterns and prescription records needed something more concrete before anyone could be charged. He requested a court order to exhume 3 of the 14 bodies. The order took 11 days to approve. Families were notified through the Attorney General's office. 2 consented immediately. The 3rd family took 4 days to respond. Their delay wasn't resistance. It was grief reopened without warrant. The exhumations were conducted quietly, no press, no public record, restricted access. A forensic pathologist named Dr. Stephen Cord performed all 3 examinations personally. In the first body, digoxin levels were inconclusive. Degradation over time had made precise measurement impossible. In the second, the results were the same. Rourke said nothing publicly. But on the 3rd examination, Howard Greer, Cord found something. Digoxin concentration levels significantly above what any prescribed therapeutic dose could account for. Not a trace amount, not an ambiguous reading. A deliberate overdose. Bernard Cale was arrested on a Tuesday morning outside his practice. He said nothing when the handcuffs went. No protest, no confusion, just silence. Colin Dresser was taken in for questioning the same afternoon. He asked for an attorney before sitting down. The 3 wellness trusts were frozen pending full financial investigation. What investigators found inside them: layered transfer, third-party accounts, connections to 2 additional physicians in neighboring counties, suggested the operation in Harwick County was not where it started. It was simply where someone had finally looked. 14 names on a spreadsheet. That was all it took. James Whitfield, the health officer who had noticed the pattern, was never publicly credited. His name appears nowhere in the official, just a footnote referencing a routine mortality audit. Filed. Process. Almost ignored. Real cases don't always make headlines. Subscribe to Case Without Name will find them.